Yeah, I'm a child neurologist, and I'm going to be talking about adults. And I think the very fact that I'm a child neurologist talking about the adults reflects the challenge that we're facing here, which is really sort of an ignored population of individuals that now finally is being recognized to have a disease. And so I'm going to talk about the burden of X-linked adrenoleukodystrophy in females. And just a quick disclosure that I'm an investigator on a bunch of products and patents, but we're not discussing any of these here today. So what I'm going to try to do is just to, I know most of you are affected by ALD anyway, but still give you a brief introduction about what is actually ALD, how is it inherited, just to make sure that we get our basics right. And then talk about what percentage of females who have a mutation are actually developing neurological symptoms and disease, and when does that happen? And do females develop cerebral ALD? Do females develop adrenal disease? And then talk a little bit about the research studies that are happening globally at this point. So ALD is the most common leukodystrophy. When you combine the incidence of females and males affected, it's actually more 1 in 13,500. 1 in 17,000 is more the data coming from older studies. And it's all due to mutations, or we now call them more variants. I'm not a person of language, so I still prefer the word mutation, because variant just means a change, but we're talking about pathologic changes in the gene. And the gene is called ABCD1, and so this gene ABCD1, also known as the ALD protein, is basically the encoding a protein, a transporter that is sitting in the membrane of these organelles inside our cells called peroxisomes. All our cells have peroxisomes, and what peroxisomes do is they basically are these little factories inside our cells that contain a bunch of enzymes that break down chemicals. One of the big chemicals that they do break down are fatty acids. And so when we eat fats, there's different types of fats. There's short chain fats, there's medium chain fats, long chain fats, and very long chain fats, depending on how many carbon atoms each fatty acid has. And so the machinery that is responsible to break down the very long chain fats is sitting inside our peroxisomes, and these very long chain fats are imported into our peroxisomes using this ALD protein. So it's a transporter, and so when you have a change in this protein, when you have a mutation in this protein, it doesn't bring the fatty acids inside the peroxisomes for degradation, and then therefore the fatty acids don't get degraded and accumulate inside the cell. And when they accumulate inside the cell, they cause all kinds of things, and I don't want to get into the very complex pathophysiology, which is still sort of being investigated. But what we have found out over the last several decades since the gene was discovered in 1993 is that there is now close to about 2,000 different changes in the gene, and I think some of you listened to Dr. Kemp's talk earlier today, or yesterday perhaps, where we see these changes that are sometimes very unique to each family. And so the more we study this disease, the more mutations we are finding. And so far we know that, as far as we know, all of them are resulting in a lack of function of the protein. So the protein doesn't work as well as it should. And so in males, where the disease was first described, it has different phases, this disease. And what we do know is that about 90%, perhaps even more, 95% of all males will develop adrenal insufficiency, Addison's disease. So the adrenal gland is basically sitting on top of our kidneys. There are two glands, one on each side. And what they do is they produce steroid hormones. And so, cortisol is the steroid hormone we all know of. But then as a consequence of not having steroids in this condition, you're missing corticosteroids, mineralosteroids, and also sex steroids like testosterone. And so there is basically two forms of steroid deficiency that you can have. You can have corticosteroid deficiency or mineralosteroid deficiency, and they look clinically a little different each. And you can have either loss of one pathway or loss of both pathways. Both is called adrenal disease. Then about that, and that can happen at any time in life. And we thought adrenal disease never happens in boys less than 2 years or so, but now with newborn screening, we actually have some babies that are only a few months old where we start seeing laboratory changes already very early on and go on steroid supplementation very early on. Childhood cerebral ALD is the classic thing that everybody knows about. That's affecting 35% or so of all the boys. And it's this rapidly demyelinating brain disease. And again, I think most of you know about this. So it tends to affect the posterior part of the brain. It's a very symmetric type of lesion. So you see it's almost like a mirror image of between the left and the right side of the brain. And the main indicator of disease progression is called is gadolinium enhancement. So you see this bright rim. I don't know if you can see my mouse button. You can or not? Yeah. And this bright rim around the edge of the lesion that, oops, where is it now? Oh, here. That lightens up, and that's called gadolinium enhancement. If the boys don't develop cerebral ALD, then again, the majority of the males will go on to develop adrenomyeloneuropathy, the adult form of the disease. And then in another 20 to 60% of the adults, there's actually progression to adult cerebral ALD. And I want to talk about adrenomyeloneuropathy more because that's very much the picture that we see in most women. So it's an adult onset, slowly progressive disease of the spinal cord and the peripheral nerves. That's why it's called myeloneuropathy. Myelopathy means involvement of the spinal cord. And so the spinal cord is this thin, long structure that we have all in our backs. And there are fibers that go up and down that basically transmit information between the peripheral senses and the brain. So there is sensory fibers that start in your toe and go all the way up to your brain. And then there are motor fibers that give the signal to move your toe that start in your brain and go all the way down. Now, if you think about these nerves, I'm 6 foot tall, or I don't know, are you using now still the foot or the metric system? Metric, okay, good. So I'm 183, right? So 183, which means the longest nerve cells in my body are about 183 centimeters long, if you think about it, because they start in the brain, they go all the way down to my toe and vice versa. And so this is a so-called lung tract disease. So the longer these nerve fibers are, the more likely they are affected. And therefore, the distal extremities, so the legs, are the primary area that starts in this disease. And actually, the vast majority of men that have AMN don't have any problems in their hand function. And so they're very strong in the upper extremities, but it's really the legs that get affected. And so one of the pathways that is critical for us to be able to walk without falling is proprioception. It's one of the senses that we have is proprioception, so measuring our location in space. And our brain is constantly, even when you're sitting now, you're not thinking about it, is constantly measuring how you are sitting. It's measuring through mechanoreceptors that are built in your skin, where your foot position, when your thigh position, when your ankle positions are, and calculates based on that exactly how you're sitting, how you're moving. And every step that you take, there's a lot of processing that goes back and forth between the peripheral signal that goes into the brain, bringing that information, and vice versa, motor signal coming back, telling your body exactly how to move. If you don't know where you are in space, you don't know how to walk. There are people that have, due to some illnesses, acute onset loss of proprioception, and they lose completely the ability to walk. That's also animals. When we knock out the proprioceptive pathways, they're no longer able to walk. But even though they have motor strength, because they're not getting that signal input, they literally don't know where they are in space. And so one of the first pathways that's affected in this disease is the pathway proprioception, because those fibers, they are coming from your toe, where I'm standing right now, and carry that signal in the back of the spinal cord all the way up to the brain. And so if that pathway is affected, you start having balance issues. And so we call that ataxia, but as opposed to what we call cerebral ataxia that comes from the hindbrain, this is a form of ataxia that we call sensory ataxia, because you don't feel your position in space. And so the very first symptoms here are balance problems because of that. And then later on, you can also have other sensory deficits like loss of sensation, but many times it's more pain, tingling, burning sensation. And that can be either because of the pathways in the spinal cord, or it could be actually the peripheral nerves themselves that are carrying that signal that are affected. So you can sort of get overlapping symptoms, whether it's the spinal cord or the peripheral nerves. And most patients actually end up having both. They have some level of neuropathy when you examine them in detail, and a level of myelopathy. The other symptoms that usually follow later, usually the sensory symptoms start first, and then the motor symptoms come a little later, is weakness. Weakness as a result of the muscles just not getting enough innervation from the nerves. And the biggest muscles in our bodies are our leg muscles. The biggest muscles in our bodies are the ones that are actually holding our hips, right? And so the glutes and the quadriceps, these are gigantic muscles. They get a lot of nerve innervation, and they are the ones, therefore, that start to get looser or weaker first. And so oftentimes you don't measure your hip flexor or hip extension when you walk. You don't think about it, but that actually starts giving you a wobbly gait. And so it's one of the first signs that we see is some hip flexor or hip extensor weakness in these patients. Along the same time, when you lose your muscle strength and muscle innervation, there is an automatic reflex that starts kicking in within the spinal cord that then results in spasticity. So spasticity is when actually your muscles get stiff. And the reason they're getting stiff is because the brain is no longer telling the spinal cord to relax those muscles. And so you get this combination of spasticity with weakness, which is sort of a little bit of counterintuitive when you first think about it. You're like, wow, it's stiff, but at the same time weaker? Yes, that's really what we start seeing. And sometimes it's antagonizing muscle groups. But that affects all your gait and your ability to walk. One of the other very early symptoms, and I'll come to that back later in females, is actually bowel bladder dysfunction. The bowel and the bladder have a very complex neural network that innervates them and regulates them, especially when you think about it, it has to be highly coordinated. For example, for urine to come out, there is a sphincter in the bladder that has to be released so that the gate sort of opens for urine to come out, and at the same time, the bladder itself has to contract. And if that doesn't work in a coordinated way, if there's bladder contraction without the sphincter opening, then you feel like you need to go, but you can't go. Or if the sphincter is open all the time, then you have incontinence. Or if the bladder is weak and is not contracting, then it fills up with urine, and then you can sort of get too big of a bladder that then becomes incontinent because it just overflows. So these type of symptoms are very common. Sexual dysfunction in man is extremely common, erectile dysfunction. And then when you have peripheral neuropathy, there is different types of nerves that we have in the periphery. There are some thick motor fibers, and then there are some thinner fibers. And so we just talk about regular neuropathy, and we talk sometimes about small fiber neuropathy. Small fiber neuropathies, small fiber neurons are basically nerve cells that are usually involved in regulating tiny things. And so one of the tiny things they regulate is our blood vessels. The reason when we stand and our blood doesn't all end up in our feet and still our brain circulation remains is that we have basically sensors in our blood vessels, in the tiny vessels in our feet, that measure how much pressure there is, and if there's too much pressure there, they contract the vessel so that the blood is pushed up towards the brain to always maintain the blood circulation in the brain, regardless of how we are positioning ourselves, right? So when you're laying down, your blood is distributed across your body. You stand up, all the blood goes down, but that doesn't actually happen because those vessels immediately constrict, and so the blood circulation is maintained into the brain. Now, that process requires nerve cells that measure that contraction of the blood vessel and make sure also that they're dilated or contracted to the appropriate level. And so those are called autonomic nerves. So these are nerves that we don't control, we don't think about, right? That's just happening automatically. That's why it's called the autonomic nervous system. And so when you have a small fiber neuropathy, oftentimes those small fibers are the ones that are responsible for innervating these tiny vessels. And so you get, as a consequence, what we call dysautonomia. So a dysregulation of this autonomic control. And so what you can end up as a consequence is that when you do rapid changes in your position, you're laying flat and you stand up, you start getting dizzy. You often get fatigue and weakness when you're having prolonged standing because there's just sort of this continuous lack of flow to the brain. And some other symptoms that we see. And that's becoming a more and more recognized part of this disease that often goes sort of ignored. You know, people have this chronic headache, fatigue, positional changes every time they stand up, and that's actually potentially partially treatable with sort of giving people more fluids, giving people more salt to sort of raise the blood pressure, and then sometimes we can actually give them mineral steroids to supplement sort of to again raise the blood pressure overall. So I spent quite a amount of time talking about this because this picture, which is in the males, very much is also seen in the females. And when we think about how ALD is transmitted, we used to call ALD an X-linked recessive disease. And this is, in the old genetics terminology, we talked about recessive and dominant disease pattern. And this recessive pattern means that when you are when you talk about X-linked inheritance that's recessive, that means that the females are only carriers, which means they have a change in one of their 2 X chromosomes, but they don't get symptoms, and therefore they're just carriers and they pass it to the next generation. Now we very much recognize that while the picture is different between men and women, they do develop symptoms, the vast majority do, and we'll come to that in a minute, and therefore it's really not appropriate to use that terminology of a recessive pattern, even though it's not really dominant because the picture is not the same. And so, but just to review this idea here, so if you are an affected mother who has one change in one of the X chromosomes, you still have one normal X chromosome, right? So you can pass either the normal or the abnormal to your children. So whether you have a son or a daughter, you have a 50% chance every single time to pass on this disease. When you are a male, because you only have that one abnormal X chromosome, and you only give the X chromosome to your daughters, you never give it to your son, right? Because your son needs your Y chromosome to be a male. So always your sons will be unaffected, and all your daughters by default will be affected because that's the only X chromosome that you have. So when you are a male with ALD, all your female offsprings will have ALD, and none of your male offsprings will have ALD. But there is a process called skewed X inactivation. And so that's basically what nature does is nature tries to keep men and women kind of the same, right? I know, I don't want to get into politics, but more or less we claim that, although I think women are smarter, but in order for nature to do that, it basically needs to shut down one of the 2 X chromosomes because men have only 1, women only have 2, and so that process is called X inactivation. So when you have an embryo, very early on, there's this random process where in each cell, one of the X chromosomes is shut down. And usually it's a 50-50 situation. So half of your cells have one of the X chromosomes shut down, the other half of your cells have the other X chromosome shut down. There is a process called skewed X inactivation, which we see sometimes. Skewed X inactivation means that for whatever reason, there are more cells that have one of the X chromosomes of the 2 X chromosomes shut down. Now, if you have ALD and you have a situation where one of your X chromosomes has a mutation, and you have a skewed X inactivation, and it's skewed towards that mutation, then you end up having more cells in your body that have the abnormal X chromosome activated, and so you may be affected more. And so this is initially, when ALD was described in women, the thought was, well, that must be because there is skewed X inactivation and the good X chromosome is shut down in more cells in them. Actually, more recent studies are finding that there isn't really a correlation between the degree of X inactivation and the degree of regular neurological symptoms. There are those individuals who have developed cerebral ALD, that's very rare, where we actually do see X inactivation. I'll come into that. I just wanted to explain the concept before I come there. So the big question is, what % of affected females develop neurological symptoms, and when does that happen? And so part of the problem is when you are looking at incidence of a disease, you always have an inherent bias when you select patients because you only select patients who have the diagnosis. So if somebody runs around and is misdiagnosed, or if somebody runs around and has no symptoms, we don't really know that they are out there, and therefore we always have this inherent selection bias when we do these type of studies, right? Unless you do population studies, which is very hard to do. Now with the newborn screening data, we're gonna get that material, but it's too early still to really get those numbers. Because the newborn screening just started a few years ago, and so by the time these individuals are older adults, there's gonna be decades to come. So we don't really know until then. So the best thing we can do is sort of a educated guesses based on populations that are seen. And so one of the very first studies was done by my mentor, Hugo Moser, where basically he and Dr. Naidu went to the ULF conference in the US, which is similar to the Alex TLC. And so they're like, okay, why don't we just look at all the women who are here and see how many of them have symptoms. And so typically these are kids not there because of themselves, they were there because of their sons. And so they evaluated 60 adult females, and then based on that time point, they thought that 53% of those women did have neurological symptoms. And so that was back in 91. Then there wasn't another study until about 2003 where we published a paper looking at MRI of women who have the mutation, and the question there was, how many of them have actually neurological symptoms? And in that 76 female cohort, there were 83 who had neurological symptoms, 83%, sorry. The issue with that population was that was definitely a skewed population because these were women who actually had an MRI, and nobody would get an MRI unless there's a reason to have an MRI, right? So it wasn't a research MRI, it was a clinical MRI. So there was already some selection bias there, and so we thought that was too high at that time. But then more recent studies, now looking again at older populations, that really it seems like those numbers are probably more accurate. So there's a study from Hornadal in 2013 that basically looked at older women and said there was no female older than 50 that was neurologically intact in that small study. A larger study by Mark Engelen in the Netherlands included 46 females that they surveyed, and within that group there was 67% overall that had neurological symptoms. And then a more recent study by Dr. Schäfer and Köhler from Germany looked at 180 females. This was a survey, so it wasn't actually an examination by a neurologist, but people just reporting themselves if they were affected or symptomatic or not. And within that cohort, 71% reported that they had neurological problems. And so when we look at this, it's not just the overall number, it's also the age that is a major determinant. So here are the three studies. The first one is the MRI study we did back in the early 2000s, then the Dutch study in 2014, and the more recent study by Dr. Schäfer. And the main observation that I want to point out here is that it's age dependent. If you look at the cohort that's only between 20 and 40 years, for example, in the Engelen study, about 20%, 18% reported neurological symptoms. Versus if you look at the cohort that was between 60 and 80, 88% reported neurological symptoms. Now, one of the things is when you get older, you have issues, right? And so, of course, if you look at the general population of women who are in their 70s and 80s, you do see that about 20% of people will have neurological symptoms, regardless of whether they have ALD or not. And so 25% of the world population has chronic back pain, and many times they have, people with chronic back pain end up having peripheral neuropathy and sensory issues. So it's a little harder to say this is all 100% related to ALD or not, but this is just the numbers that we see that certainly implies that this is not a just straightforward X-linked recessive disease. And so in the Dutch cohort, there was a very thorough evaluation of what are the symptoms seen in the women, and when you list these symptoms here, these are exactly the symptoms we just talked about in the men with ALD, with AMN, right? And so about 55% reported sensory disturbances, so tingling, numbness, pain in the periphery, in the peripheral nerves. About 46% had urinary incontinence. Actually, 28% reported also fecal incontinence. And then about 45% had a gait disorder, so they had balance problems and so on. And so this is published data. And then if you now say, okay, beyond these typical AMN symptoms, what are the other things that they may experience? We have done nerve conduction studies and so on, and also this Dutch study did a nerve conduction study looking at the upper extremities as well. And again, like in men, almost no one had any upper extremity involvement, right? Only 3 out of 46 had some nerve conduction abnormalities, but there wasn't actually clinical symptoms related to that. Having said that, a lot of normal people develop upper extremity nerve conduction abnormalities, especially at the times of typing. Most of us develop a median nerve palsy or abnormalities in the hand. And so one of the observations that I personally have, but we haven't published, is that it seems to me that if you have any risk factors for damaging your peripheral nerves, and if you have ALD on top, you exaggerate that. It's like an additional, hit. That's how it feels like. One of the important things in this Dutch study was that they did not see any correlation with that skewed X inactivation. So it didn't matter whether these women had skewed X inactivation or not. They would still experience the symptoms. And then in terms of additional things, the German study, like I mentioned, it was a survey. So these were self-reported outcomes, and it included also exploring the cognitive and the mental health aspects of this disease. And this is very much what we see in the clinic. 43% met criteria for depression. And so 26 was actually severe depression. And there was about 15% that had some suicidal ideation. So this is, for me, an extremely important factor because we've had patients we lost due to suicide, and ignoring the mental health aspects of this disease is a major challenge that we're facing. People are usually not open to it. People are just blaming it on the stresses that they have had in life, which is certainly contributory, but this is significantly higher than the average population. Okay, so this is not anywhere close to what you would expect in normal people. And 73% reported chronic pain, about 80% had sleep problems. Now again, these are issues that are common in general population. You ask an American normal 50-year plus people if they have sleep disturbances, 50% will report they have sleep disturbances. So I don't know what is defined as normal in that. 38% of females reported sexual dysfunction. And that is, again, consistent with what we have seen in the clinic. It's usually related to pain during intercourse. This is a very common thing that we hear in the clinic, and nobody wants to talk about it. There is also more recent emergence that there might be clear restless leg syndrome associated with ALD. The challenge there is that when you look at the symptoms of restless leg, it's burning, itching, pain, aching, very much the same as when you have peripheral neuropathy. So just based on a historical evaluation and based on a survey, it's very hard to tell whether the symptoms are related to true restless leg syndrome, which is a defined sleep disorder due to abnormal leg movements related usually to iron deficiency, versus having these symptoms because they have a peripheral neuropathy. But when we look at it, it's about 50% of all people seem to have reporting these symptoms. And so right now there is a clinical trial that's happening at Mass General Hospital in Boston and at the University of Amsterdam using the medications that we use in restless leg syndrome in women to see, it's a placebo-controlled trial, to see if it actually improves some of these symptoms. And that would sort of imply that, yes, this is truly restless leg syndrome. Chronic fatigue, like I mentioned earlier, about 30% of our patients in my clinic report that. And in several cases, we have been able to see that they have dysautonomia. We can do a defined sort of assessment to see if they have what we really call dysautonomia based on measuring their heart rate and blood pressure changes as they go from lying position to sitting position to standing position. There's also a test called the tilt test where you can actually put them on a belt and then tilt them. And you can find out that they have that, and you can treat that. There is also a more recent sort of question that is still unpublished and unclear is whether women may experience symptoms that go beyond what we call AMN and beyond what the men experience. And so within the Boston cohort, Dr. Eichler's group has reported that about 15% of females have some symptoms that are not typically seen in men. So they include torticollis, which is mild, asymmetry of neck position, dysphonia, so changes in their voice, a mild action tremor, and then ataxia was what they described. What we have seen in my clinic is that we haven't seen that frequency. We see it in a few women, about 5% or so. We do see some of the same overlapping things, some slurring of the speech, mild tremors, a little bit of the neck turning, and some people have head bobbing, which is, it's like this very subtle head bobbing. And we haven't seen these symptoms in the males, so we don't really know. We haven't published it. We're still exploring it, trying to understand if it's true related to this disease or not. But it's something to keep in mind. In terms of how fast it gets worse in women, overall, there's always been this saying, but the disease is much milder in women than in men. When you look at it, it really depends on what aspects of the disease. When you look at walking speed and hip strength, you see here the blue are the guys, the red are the girls. In the study that we did at Kennedy Krieger, when you look at the walking speed and you look at hip strength, you see that in the guys, it does go down over a 2-year period, versus in the women, it's basically a flat line. So there isn't any worsening as fast as in the men. Well, over decades, yes, but yes, so in terms of strength, it seems that it's getting worse faster in men versus in women. However, when we look at sensation loss, abnormalities in their sensation, we see that both men and women are essentially progressing at the same rate, which is that graph on the right side. It's slow, though. You see this slight increase in abnormal sensation over a 2-year period. When we look at balance, when we have people stand in one point and see how much they sway in space, that's the best metric for proprioception, so sensing yourself in space. We see that the rate of progression is actually the same. It's milder than in women, but you see these curves, the blue and the red curves, they're parallel to each other, which means women do get worse in terms of their balance at the same pace as in men, except that it's just milder, but it does get worse. And so that's over a 2-year period. Now, a couple quick discussions is, do women develop cerebral ALD? This is a question that often people ask us in the clinic, and we actually have only done one study to really systematically try to answer that. That's the old study that I mentioned. And in that study, we found that out of 76 women, 3 had true cerebral ALD, which would be very much the same as in the boys in terms of the pictures and the MRIs and the rate of progression. Having said that, again, that study was skewed towards women who had an MRI for a reason. So there isn't any systemic study looking at every person who has the gene mutation. And when we look at our clinical experience, and I'm going to skip this, these are just the 3 cases. When we look at our clinical experience, we have had probably this was a study between 1990 and 2000. Since then, we have had about 200 or so more females in our clinic, and we have had 2 more cases. So we have about 5 cases out of about 250, right? So that's somewhere on the order of 1 to 2%. And we think that in those cases, this is skewed exon activation, and that's really, really rare. So generally, many places you go, you will get an initial brain MRI and start having neurological symptoms, but we don't recommend having repeated MRIs every year like in men, because it's extremely rare to have that. So we basically don't worry about it that much. Similarly with adrenal disease, this has been looked at more systematically. There is a study that has looked at 71 women. This is actually an old study. In that study, there was 1 out of 71 cases that had clear adrenal insufficiency. 4 cases, however, had mildly decreased aldosterone levels, which is the mineralocorticoid. And so this is the one that can exaggerate your dysautonomia. And so we, at Kennedy, we do screen everybody at baseline for adrenal insufficiency, even though it's rare. Overall, we would say we have about 3 out of 200 patients that have clear adrenal insufficiency right now in active care. So that's about 1.5%. So again, it's unlikely, so it's not something where we would do it as frequently as in the males, the monitoring. And then I just want to finish up by quickly saying, I know I'm over, sorry. There was some technical issues first. But so in terms of what research is happening, I already mentioned the clinical trial about the restless-legs syndrome. But there's also natural history studies that are happening in Germany, in the Netherlands, and within the US between MGH and us. We have a consortium called the GLIA Consortium, where we are prospectively collecting natural history data to better understand and come up with better answers with these questions that I just brought up. There's also a recent biomarker study that we just started to see if there are blood biomarkers that we can use to predict who you're going to look like in 5 years from now, basically. It's like a predictive study. So just elaborating on that a little bit, we use measurable, one of the main things we focused on is that swaying that I mentioned earlier. You can quantitate that nicely so by putting sensors on your feet, and then actually you can do that in the patient's home. And we just recently showed in a paper that was a collaboration between Dr. Engelen's group and us in 2 different continents, 2 separate studies, that using this sway is a great predictor of trying to distinguish who needs a cane or not. So we can see here, for example, on the right side, that women who don't need the cane have much less sway than those who do need a cane. So you can actually use that sway variable to predict when is a meaningful change when you're doing a clinical trial, when we're doing a drug trial. And so, I'm basically going to end it there, but just saying that there is a paper that was published last year that was international recommendations about management of patients with ALD, and we did include females in here, although the recommendation has been basically like start looking at them neurologically every 1 to 2 years. Again, at Kennedy Krieger, we get adrenal testing at baseline in everybody who comes to our clinic, and then only do it later on if they have symptoms. Many women end up getting an MRI when they start experiencing neurological symptoms, which I think is reasonable because you always want to make sure it's not something else, just in case. People can have 2 diseases. And so, but we don't monitor the MRI every year like we do in the males. So I'm just going to thank again for the invitation and for questions. I guess there's a break now, so I'll stick around.
Is this one working? Okay. Thank you guys so much for coming. I didn't want to stop it too short, but because I knew it was a good presentation and obviously, yeah, so just